So basically, you all have to talk. Otherwise, don't wait without wasting time. Now, you all are in the final year. All these things have been done before. And just tell even the wrong thing. That's okay. We are not giving marks. But we have to correct and give you the best knowledge now. The correct knowledge you all should get. There is no chance anymore. No? So next February, March, you will be having the exam. No? So today itself, we'll try to finish off as much as possible and retain in your heads. Although people are not doing pediatrics, even the others can still contribute. And now you all are in the third appointment, or?
No, sir, second appointment.
Second one. Okay. So there will be 1.5 groups or 2 groups who in pediatric had been. But this is not a total pediatric, it's a total MBBS topic, no? So nutritional disorders in children, the main ones which we will try to discuss. And if you all have any questions, please then and there ask. You just shout and ask. So the main health scenarios are the poor weight gain in infancy and breastfeeding issues or feeding issues as whole in young children. Then obese child is one of the biggest problems we are facing day by day. Micronutrient deficiencies. Out of that, anemia is the key one. There may be other micronutrients which we are not looking very much. We don't have that much of facilities. Then, of course, short stature and delayed puberty, which is also another issue. So we will discuss some of them based on clear case scenarios. So infant feeding is one of the key things, and we know that there is something called IYCF, infant and young child feeding practices. So it is mainly trying to reach for normal physical growth, and we want to have the optimum brain development and also have a good immune system functioning with prevention of illnesses. So these are some of the key objectives of a feeding what we expect out of infant feeding. Now, please go through this case scenario and quickly tell me what do you plan to do. So a mother brings a 6-day-old baby with a complaint of poor milk secretion. This is a common complaint you will encounter in any unit where you are working. I'm discussing about peripheral units where you will be seeing first contact after your internship. So birth weight is 3 kilos. Day 6 weight is 2.8 kilos. Urine is 3 to 4 times yellowish green in color stools. And child demands feeds 1 to 2 hourly. What is the initial step in the management of this child? Or how would you manage this child? Please discuss quickly. Otherwise, it's just it should not be a lecture. And I'm sick of giving these Zoom lectures. So we will talk at least, right?
So we have to correct the breastfeeding technique of the mother initially.
Now, is there a problem? Now the mother is alarmed about this weight drop.
So it seems.
What do you think? What is your overall assessment of this situation?
It seems that there is some sort of problem because by day 6 there is a weight drop by 200 grams, which is usual, which may be usual because we expect about 10% weight loss in the first 10 to 14 days. So it falls within that range, but urine passing frequency seems to be a bit low, 3 to 4 times. A day 6-old baby, we expect to pass about 6 times urine 6 times per day. So that that may seems to be low, and the complaint of poor milk secretion is one of the commonest thing that we encounter in the very early age. So and the child is also demanding feeds every 1 to 2 hour, means like usually like after every feed, they, if it is a very adequate feed, they tend to sleep for about 2 hours minimum. So this seems that there is a kind of inadequacy which I feel. So which we can like advise the mother, because we have to stimulate um, um, we have to stimulate milk production by just increasing the bonding which can be achieved. So skin to skin contact and promoting the by stimulating the mother and the baby bond, we can increase the milk production, I think, in this case, and that we can manage in that sense.
Right. Okay. So the weight drop is you're not alarmed.
Not, sir.
Yeah. So that we have a levels of about 300-gram loss, and we have lost only 200, and then by day 10 we expect it to come back to normal, which is within. So urine, yes, there is a little bit of a reduction, but stools also seems to be now meconium is passing off, and normal stool seems to be appearing yellowish green. And then there is, of course, yes, an increase in feeding demand, of course, with the weight drop as well as child becoming bigger and bigger. So what exactly will you tell the mother then? What are the
Uh,
aspects? Somebody,
Reassure the mother that this is an acceptable weight loss, and usually the baby doesn't need much during the first few days. Like the quantity of milk that's needed for a baby in the first few days of life is like 5 ml, and then like within like 25 ml. So mother may think the baby might need more milk than this. Since the condition of the baby is not alarming, we can reassure the mother that this is normal.
and what would you do? Hmm? So you reassure. So you say,
we,
okay,
we
the mother child can lose 200, 300 grams. He has to lose 280. On day 10, the weight will come back to normal. So you seems to be getting some amount of milk. So that's why child is at least passing 4 times of urine around that amount. And the stools also have now getting better into the normal color. And then, okay, you say, okay, don't worry, go and give milk. Right. Now, what else you should be adding on to this? Anybody?
so we can ask the mother to keep the baby skin to skin in a kangaroo kind of kangaroo cap position, and we can ask the mother to be uh, most more receptive to the stimulus that the baby is giving, so that that connection will eventually promote milk production, sir.
Right. So, do you think skin to skin contact or thinking positively about the baby alone will improve the milk secretion?
Uh, that will improve
Huh?
a lot, sir, because these are hormonal
Yeah.
phase, which I feel so that can help us to a great extent. Other than that, proper nursing technique and by assessing the breeding, the attachment, positioning, and establishing the breastfeeding in a proper way will also one of the aspect in the
Right.
management.
Okay. You have to position, you have to get attached properly and do it. Right. Then what else? Now, milk is what? It is produce something by the mother. So to produce that, what she needs for any production, what do you need?
She needs nutrition. We have to.
We needs raw material.
Yeah.
So what is the raw material that this lady would need? Think
She should
simple.
she should also take more calories and
Okay, take a reasonable good nutrition. Then what? What else you need? What is the composition of milk? Nutrients,
Adequate hydration, sir.
water.
hydration. Without what now? You and I know if we don't take enough water, our urine output is low. So urine is also something produced in the body. So like that, milk is also something. And people think most of them, they have a false sense of this thing, belief that you have to drink milk to produce milk. Then I asked whether there is a esophageal mammary fistula for that. Otherwise, you can't know. So the main thing is because why I say that it is, I mean, in the different manner, because people spend a lot of money unnecessarily on these milk powders, which you would see that this mama milk products, which is actually a gimmick. If you just eat even post-del with a reasonable amount of other animal protein like fish and especially fish, and then something like an egg a day, she can produce enough. But see, the important thing is the freely available water should be given. Because if the mother is dry, dehydrated, then she can't. Because 90% of the composition is water. So if somebody is to produce 700 milliliters of milk, then definitely 600 to 650 milliliters will be water. So you have to give that. So you have to tell them, right, especially in a country like ours, where the hot, humid, lot of perspiration takes place. Right. So that's good. So you don't start anything because these people, they are worried when the weight drop occurs. Anytime a 50-gram drop occurs, even difference on the weighing scales, they will be very worried. So you have to tell them this is the normal phenomena. That is where. So given these answers, what do you think would be the most appropriate? So almost all these are also correct in certain contexts.
Observe techniques of breastfeeding.
Observe technique of breastfeeding and correct and help her basically. So it is on establishment of lactation because there is no lactation failure here. It is only taking a little longer to initiate, and this may be a primary mother, not much of having family support, not much of experience, so all that. So you have to take all that into consideration. But of course, in certain conditions, if the baby has a problem, you may have to express and give feeds through nasogastric tube. And if the mother's secretion of milk is very poor, if there is a huge drop in the weight, then of course you may have to start formula milk, but that is the last resort. Then to improve milk secretion, you can start the mother on lactogogue, improve lactation. If the child is lost weight and if there is danger of developing hypoglycemia, then you may have to give even dextrose sips or even go for IV dextrose. So all these answers are can happen as possibilities based on the other information is given. So if we had added the child had been developing jitteriness or frequent episodes of hypoglycemia, then you may go for dextrose dip. So like that. Or if the mother is not available, mother has undergone something, then you may have to go for formula milk. So like that, depending on this. Now you can see this is the minimum amount of information. Based on that, this is the first thing because you have to, the primary problem here is we are not told anything other than the current situation, and usually it takes about 2 weeks to establish breastfeeding. So that is one of the main things you should remember. And during that period, you can see various changes, and you have to do things as prophylactically. That is good nutrition, good rest, adequate hydration. Plus or minus in certain cases, you can start even medication to improve, but that is not a routine thing. So, any questions on this? Okay. Right. So, what is exclusive breastfeeding? Why do we breastfeed? So, breast milk is the ideal food for a healthy growth and development. So, what is exclusive breastfeeding? Can anybody tell me quickly? Say something. You all know something. You may not get all the wording correct, but at least tell something quickly.
Exclusive means giving breast milk uh, purely, no other feeds or whatever the things to the baby. Baby is dependent completely on the mother's milk, which is
To
usually
provide
given up
what?
to 6 months to
To
provide
provide
the nutrition and the water hydration.
hydration and nutrition. Yes. Any exceptions? So it is
The medications.
exactly. So it is providing milk as the exclusive source of energy, nutrients, and hydration, but medicinal drops are allowed. So this is child is given only breast milk as the sole source of nutrient and fluid. Medicinal drops are accepted. So because some people have a myth, ළමයාට දැන් බේත් දුන්නා, now the child is given this drop, that drop. Because of that, it is not exclusive breastfeeding. No. At 4 months, if you assess them and say, now what have you given other than breast milk? They will say, we have given this iron drops or something, or the child had a cough or something and an antihistamine or bronchodilator was given. Then you have given something killer. Some people in these evaluations and all, they drop. No. It is, if something was given in the intention of providing the nutrients or the fluid, then of course it is a breach of the exclusive breastfeeding, but giving medicine is not so. So that you have to remember. So what we say is that to give exclusive breastfeeding till 6 months, right? So that is not a regulation or law, but that is accepted thing. However, there could be always exceptions to the rule. So can somebody tell the answers to this? Ikman. Come on.
True, sir. First, second true.
True.
Second true.
Second true.
Third true.
Hmm.
False.
False.
False, sir.
False.
What is the answer to what is the true statement would be for 4?
Oh, it moves as lactose.
Lactose.
Now, if you look at this, you may see this is as a theory question. Yeah. But this theory you need for the day-to-day practice. Now we know iron, because sometimes people get confused when we say 50% of the iron is available in bioavailable. So that means bioavailability is very high, but the amount of iron that is available in breast milk is very, very minimal. So it will not provide adequate required iron as a dietary source, and then you have to give iron. But if the child is a term baby from a well-nourished mother, then of course till complementary feeds are started, he can do well. Then whey casein is important of the curdling effect and things like that. Then the immunoglobulins that has immunity, this thing. So that's why sometimes people will come and say, I have got contracted a respiratory tract illness. Should I be feeding the child? Yes, you should be feeding the child, because by the time you have contracted the illness, the child may have got it also. But more than that, the immunity the mother will develop fast, so the mother can transfer the immunity quickly to the baby. Fructose is not the sugar, it is actual lactose. So that again has a practical this thing, because that is the brushboard enzyme, which is very easily destroyed, digested the disaccharide into monosaccharide. So then in diarrheal illnesses and all, we have that practical implication. Then more protein than in cow milk. No, it is the other way around. That's why the less curdling and thinness of the milk is there. So advantage of breastfeeding, you all know, both advantage of breastfeeding to the mother as well as the baby is there. So you have to know those things. That is theory. This is again a comparison of, so you can see the amount of protein is the main thing that is different in the 3 species. That is also based on the rate of growth. Then this is an important part because human milk and cow milk is the one which we commonly use as a manufactured product, and you can see that the casein load is very high, whereas casein load is very low in human milk, and that has its own benefits. Then, of course, this is one of the, again, practical importance that if you see the colostrum, it is having nutrients. It contains fair amount of protein and fat, which is required for the baby, but less lactose. But when it comes to the mature milk, you can see how the composition varies. So that is why, because sometimes some people do a practice that after 10 minutes they shift the breast. So that means the child will be fed only with foremilk. And you can see that the hind milk contain a lot of fat in the had a lot of fat. So that will help the child almost double the fat content of the foremilk. So that means it will provide a lot of energy. So the child may grow, other parts are there, but his especially weight gain will not happen adequately. So that is why you have to tell a mother to empty a breast before they shift on to the other breast. Usually a baby could be sufficiently fed with the amount of milk produced by a single breast at a time. But there is something that people think that both sides should be given this and that. So, but of course, it is important to empty a breast and get all the hind milk also to the baby. Sorry. So, let down reflex is important for milk secretion, lactogenesis. Then number 3,
True, sir.
true. Okay. Why?
If you empty the breast, then there will
Yeah,
be
there is,
more in the reflex there will be more milk production. So that's
yeah.
why we ask the
Usually the human female has the capacity to meet the demand. So that's why successfully she can even feed a set of twins. So that's why I said one breast milk secretion is more than enough for a feed for a baby. So she has a pair, and if they produce has a twin, the both of them could be very nicely fed, because I have experience with about 4 or 5 sets of my patients where they have done very well till 6 months. Right, then number 4, cerita Tino.
True, sir.
Yes, it changes from, definitely one female's milk will not be equal to the other females. And within the same female, during the day, I'm not talking about a 6-month variation. Definitely it will vary, and after about 5-6 months, the composition or the quality of the milk will also go down. But of course, within the day also, depending on the normal circadian rhythm, as well as mainly with the diurnal variation in the diet and habits and all, the composition will vary. Then number 5, quickly.
False, sir.
It is actually true because it has breast milk lipase that will help in the digestion, right? Okay, so those are the things. So now this is again another scenario. My child is poorly feeding and I feel I don't have enough milk. Then the next question is, can I start formula milk? This either comes originally from the mother or because of the pressure coming from the in-law sometimes, right? So what would we do? Hmm? So what is the approach? Can somebody quickly tell me in 2-3 minutes? So the mother comes and says, I don't have milk. Can I start formula milk? So what is the first step you would do?
First, we have to assess mother's.
Say this is about a 1.5 or 2 month old baby.
First, we have to assess mother. So we have to take a good history whether she's like not willing to feed the baby by breastfeeding, or there are other illnesses with mother or something like that, reducing her feeding.
Okay.
And then we have to assess the attachment and breastfeeding technique.
Mm-hmm.
And we have to take a dietary history of the mother to assess the nutritional state of the mother, because it will affect the milk production of the mother. And we have to assess the child for any illness or uh, illness, because it will reduce feeding.
Right. Any other answers? Anything addition or?
So I think, and also we should measure the height and weight of the baby and plot it in the charts and see whether they are he's up to what is being expected, or is he in the malnourished areas.
What the first, both of what you all said was quite true, and absolutely spot on is number 2 answer. Because first of all, you have to say, now this the mother comes and say that child is not feeding, and any mother in this country, my experience over the last almost 25 years is that every child is not feeding. And first of all, you have to tell them, you have to objectively show them whether the child, and you have to know whether the child is growing adequately or not. That is for sure you have to first identify. That is concrete. First, so you have to measure the child and then take the anthropometric and see whether there is proper growth. So then you can show the mother it is it. Then you will take a history actually more than the production side. Okay, from the production side as well as from the receiving side, you have to take the history. Because the mother may produce enough, but still there may be a problem going into the baby. So you have to take a history and see whether the mother has adequate production and whether she's taking the adequate amount of raw material required. Then whether the baby had got enough or not. So then, of course, from there, then if everything is failing and the child is losing weight, mother does not produce anything, you give her a trial of lactogog, hydrate her, and then counsel and give some moral support. And after a few days or whatever, then still you are not being able, then only you will start. So formula milk should not be started on the first encounter the patient is having with the medical person with regard to poor feeding. It is the second or third day's decision based on what you will be seeing on your examination, assessment of the growth, and then the assessment of the secretion and feeding technique adopted by the mother. So lactation failure is inability to nourish a baby whose mother's milk, with mother's milk. It can be mother's problem, it can be infant's problem, because mother may not be producing due to nutritional or hydration problems, or she may be having defects or any diseases. Now infant may also, if the infant does not take the food properly, then of course, if as we said, more emptying of the breast will increase the production, less emptying of the breast will reduce the production. Because why should they? Because nature does not waste things, although the humans do. Nature does not waste things. So what it does is, if you don't want me to produce much more, what I produce now is enough, why should I produce and waste? Because wastage will be, then there will be breast engorgement, difficulty, pain to the mother, secondary infection, all sorts of things. So the nature very well knows that, and then they will adjust. So the child also is responsible for the production of milk. Right. So then if we identify lactation failure, you have to see whether there is an improper weight gain or inadequate weight gain. So that is, you get 25 to 30 grams of weight gain usually in the first 3 months. It is roughly about 10 grams per kilogram body weight. So you know, roughly about a child is about 2.5 to 3 kilos in this country. So that's how this 25 to 30 has arrived. Then urine output, as I said earlier, or one of you all said about 6, yes, 4 to 6 diapers we expect, or nappies we expect a day. And then number of hours baby sleeps. The baby usually sleeps about, unless it's a cold day or a really lazy chap, usually they about 2.5 hours they will wake up. So anybody who does not sleep that much every half an hour or difficult to console is having a problem. Then let down reflex, that is to see the amount he produces, where once the mother begins to feed the baby, the non-feeding breast will begin to drip a little bit of milk. Then you can examine the child and see whether the child is well hydrated or not. So that will give a clue. So those are the identification factors from the child's point of view of lactation failure. So what do you going to intervene? You have to see the position, correct what is hydration. She may be psychologically down for varied reasons. There may be also fatigue that also have to be corrected. That ultimately works through the psychological aspect. Then you may give some lactogogues, that is any medication that will improve the milk secretion. The simplest, easiest is to use domperidone 10 milligram 3 times a day for about 5 days. But don't know whether there is a placebo effect or whether it is really a medicinal side effect that is coming. So but of course you can try out and see. Then of course you manually express the milk. So we talked about the emptying, the degree of emptying. Inadequate emptying will cause inadequate secretion. So how you improve is, if the child is weak, child can't really suckle and he's still learning, then of course you can tell them to express. So in practical terms, first 1 week or so, you can even tell the mother to express at the end of after about 1 hour, half an hour after feed, giving some time to produce the milk. So that the breast will not know whether the mother emptied the breast milk or whether the baby suckled. It begins to increase its production. So that's tricking the breast in a way you can get it done. So then, of course, again, as I said earlier, sometimes some people have the practice of starting on lactogogues prophylactically, probably providing a psychological effect plus or minus a medicinal effect as well. Then, of course, failing all these things and still the child keeps on losing weight, the child is miserable, find it difficult to remove from the breast, then, of course, you will have the to start on formula milk. So what are the mechanisms of milk secretion and ingestion? Now, you can see 2 pictures. Anybody wants to comment about these 2 pictures?
The first one seems to be correct, sir, because
Sorry?
the first picture seems to be a proper attachment, while the second one seems to be an improper one, where the baby is only sucking the nipple in
Right,
comparison
okay.
to the first one.
So when you say proper attachment, what are the features of proper attachment?
Usually, almost the major part of the areola is covered, like it's into the baby's mouth. So usually the baby's lips are fanged out, and uh, and uh,
Anybody? තව ඉන්නවනේ 100ක්. Somebody jump and shout, man. මුණ පේන්නෙත් නැහැ. Anyway, I don't see your faces also. No? I'm not coming to the ward.
Sir, in the areola in the lower part of the mouth, it should be covered up wholly, and the upper part we can see a small part, and the baby's cheeks should be puffed up.
What else? What is it? Mouth should be wide open. You have to actually, you can show with your index finger and the thumb. If the thumb is the lower lip, if the index finger is the upper lip, you can show it wide apart. It should be. Where you can show actually, because what people think is now when we suck, when we take anything, drink from a straw, we keep our lips closed. And when we are drinking, we keep lips closer to the edge of the cup or whatever. So people think that when the baby is having his lips quite closer to each other, it is okay. But you can see when the lips are too close to each other, here it is only biting onto the nipple. But to get the bite of the areola, then of course the lip should be wide apart. So the mouth is open as a very, very wide mouth, and invariably with that the lower lip will curved outwards, because you never see the upper lip curving outwards. No, that is how it is made, because you don't see. If you look at the lower lip, between the chin and the lip there is a ridge. Those who know about these temples, rock temples, where kataran kapanawa කියලා තියෙන්නේ, to prevent the spilling, that is how it is been nature's way of prepared also. So there is now in the upper lip you don't see a such ridge between the upper lip and the skin. But lower lip, you can see that there is a nice skin, and that has, when you open the mouth, that gets more prominent with the lip spilling out or everting out and making this lower lip turn outwards. Then the chin should touch the breast. That means it is coming closer to the mother. And then more areola is visible above the baby's mouth, upper mouth above than below. So that is because he is holding breast from below. So that is, these are the four main features of proper attachment of the baby. So attachment is the fixing of the mother's breast into the baby's mouth. Because people think that the nipple is the main organ that will provide the milk. Nipple is only helpful in what? Nipple helps in what? Can a flat nipple lady give lactate successfully? What is the main function of the nipple from breastfeeding context? Anybody quickly? Yo, did you huh?
To simulate the sucking of the baby.
Sorry?
To simulate the sucking of the baby.
Not to simulate. It is actually to get the mouth of the baby directed toward the breast. The main function, because it is not really even required to deliver the milk to the back of the mouth. It is. I will show you a little later.
So it's only useful in rooting, you're saying?
It's mainly for the rooting. So that's why a lack of nipple is, a flat nipple is not a huge problem. Then you have to go for positioning. So the mother should be relaxed and comfortable. That's prime thing. But there are four things. Next is straight or slightly bent backwards. That is, you have to extend the neck. Now you can't, even you and I can't flex the neck and drink. No, it's very difficult because the esophagus will pinch. It will collapse more or less. Then body turn towards the mother. Body turn towards the mother. Then the body is closer to the mother, obvious. Whole body is supported. So this should be in one straight line more or less. And then the neck and the trunk are slightly extended. Body turned towards the mother, is closer to the mother, and the whole body supported. And of course, I add a fifth one, that the mother need to be seated comfortably. So because if the mother is not positioned, sometimes the mother stretch out in the give it. Then after about 5-10 minutes, she will get a back pain and all, and then she stretches out. With that stretching, again the attachment will be dropped. So that is something. And you can see here that either this way you can lift the breast, or if the breast of, especially now this is looks like a multiparous mother's breast, but in a first baby or second baby, sometimes the breast may be much more stiffer. So in that case, she should not be putting a lot of fingers underneath. Maybe she fold the ring finger and the fourth and the fifth fingers. Then with the first, second and third finger, she raise the breast like this. And then the thumb is only to prevent overlaying or the breast tissue falling onto the nose of the baby and getting disturbed. So this way, so this finger will help to stretch the breast backwards and prevent it falling onto the nose, while these two will raise the breast to upper level, and that will help the breast fall into the baby's mouth. That is the important thing, because sometimes what happens is they will keep both the index finger and then the thumb very close and try to push the nipple into the baby's mouth. That will not work. So you have to tell them just to rest it and just let the breast fall into the baby's mouth. Sorry. So if there is poor attachment, there will be painful nipples because the child will be biting. Then there will be damaged nipple, poor emptying of the breast, which will lead to engorgement. Baby unsatisfied, cries a lot. Baby feeds frequently, decreased milk production, and baby fail to gain weight. So then you have these reflexes. So this is the best way to find out whether a baby is hungry, because sometimes the babies will begin to cry. And when they cry, they think always a baby cries because he wants something to drink or the milk. So the best way they can identify is that the mother can either touch the upper lip with the finger or even with the nipple. So imagine this is the nipple. So this nipple provides the task of directing the baby to turn this way and suckle. So nipples are actually to direct the baby, and this is the rooting reflex, sprouting reflex, then sucking, and then it will have the swallowing reflex. So how does the baby extract the milk? The baby will extract the milk this way, right? So here you can see this is the nipple. Now these are developed based on the ultrasound scan of the mouth when the baby was suckling milk. So you can see that the baby is not really biting or crushing the nipple. There is no indentation in the nipple. You can see it is more or less just being continuously pressed, squeezed. And then this is the tongue of the baby, and this is the hard palate, this is the soft palate. So you can see the milk is actually, the tongue is not really moving as is pressing onto something, but it is just giving room from this end, and you can see that it creates a vacuum, and you can see the nipple does not really reach to this part. So people sometimes think when you hold the baby so close that the child will get choked. There is nothing like that. And milk is just only being directed towards the latter part. So you can see even the nipple was ending here, still the baby will be able to feed effectively. So what they say is it is actually creating a negative pressure in the mouth that makes to removal. So that's why if the mouth is, when the mouth is wide open, the breast can get really fixed into the mouth. But if the lips are close to each other and holds on to the nipple, they will have an angle between the edges of the lips of the baby where he will suck a lot of air. So those are the ones will have a lot of aerophagia and colics. So that's why this attachment, the mouth has to be very widely open. That will help the take a good bite of the breast, and that will help to prevent the actually getting air sucked in, but only to get the suck in the milk only. So this is a vacuum plays a key role in the milk removal which comes. So you can see nicely, this is the epiglottis and this is the trachea. You can see when this is falling, this part closes and takes. So these are actually taken from real time. These are not animation, simple animation. These are real time scans that they have fed and developed it. Right. Any questions up to now on breastfeeding? Hope you all had a reasonable recapitulation of what we have learned earlier. So then, this scenario, exclusive breastfed child 4 months brought for routine immunization. Weight of the child is low, plotted on the chart. Development the child is normal and appears well. Comment on the growth of this child quickly. But we have already gone 1 hour. Anything?
Earlier, the child was traveling along the -1 ST line, sir. And now he is starting to deviate towards -2 ST. And it's a 4-month-year baby. Otherwise,
4 month years nෑ. 4 month
Sorry,
years
four-
නෑනේ.
so-
කවුද මේ 4 month year මගුලක් කියන්නේ? 4 month, right?
4-month baby.
Remember that it looks very ugly. Right, then?
It's a 4-month baby. Otherwise, it seems healthy, sir. Weight is also 5 kilograms. So,
Right. So what are you going to do?
I think this point we have to start the weaning and we have to start the complementary feeding, sir.
Right. What would you take regard the feeding of this child? So you want to start complementary feeding.
Yes, sir.
Out of these, what do you think? What is the answer?
Answer is A, sir.
A. Express breast milk will not work at this time because you can see till 3 months child had been growing very nicely. And then observant technique of feeding or midwife like now she had been giving this milk very successfully for 3 months. Unless she had really gone nuts or something, no. This quite clearly shows that the amount of milk or the energy supplied by the mother has been outgrown by the needs of the demands of the child. So it needs to be matched now. So recommend type of feeds with formula? Definitely not, because at 4 months you can start complementary feeds. Start mother on medication and improve lactation? No, you can't, because mother had been doing very well. So that you have to see that the mother had done well, and now it is a new incident, so that can't be, unless of course the mother was ill or something, or there was separation or psychiatric illness she developed, she refused or something. So, but overall, based on this, what you have to do is you have to start complementary feeding, because I want to drill this message properly, because if you don't feed at this point, then මාස 6 වෙනකන් compliment කිරි දෙන්න කිය ඉන්නකොට මෙතෙන්ට පහට එනකොට it will be like this, because now they will go on a trajectory like this. So then they will gain, but it will be ultimately in another 2 months time. At 6 months they will be like this. So you can see now the deficit is about 400-500 grams, but if it comes to 6 months it would be of course almost closer to a kilo. So then of course recovering them will be very difficult. Then what will happen is then they will be just going on this line. So it's very important that you identify this. So the most important time of manage or looking at the weight is at 4 months, 5 months and 6 months. So one of the commonest points of complaint is poor growth. Need to objectively assess the growth and then advise. Then how to achieve proper growth is regular monitoring of the child and exclusive breastfeeding carried out with supervision. So you have to, just only telling the mother to give milk is not going to be enough. And if you are serious about stopping malnutrition and trying them to grow, because you have to remember not only the weight, the height will also be short. So if somebody loses 2.5, 3, 4 centimeters at the end, then it is not nice, because if they could have gained that, that could have been helped a lot. Sometimes people may have lost jobs even because certain jobs reach certain heights. So if they can't get that, then it's a loss. So you have to do that. And then the timely introduction of weaning. So what we have done here, we have had the regular monitoring in the previous chart. So we have been exclusive breastfeeding, and at one point we have seen it is not enough because we supervised that, and now we have introduced the complementary feeding. So this is the whole hallmark of this IYCF at the complementary feeding part. So what about this? What do you tell?
Babies in the growth line of mean growth line, and there is no deviation from that line. So we can, as he's only she's only 5 months old, we can continue to exclusive breastfeeding for another month.
Yes. Now this one is contrary to that. This child and mother is quite okay, supporting. I mean, the mother is supporting the baby's growth very nicely. And then the other social parameters are also there because the mother is a housewife who is staying at home. Now at 5 months, you know that sometimes the mothers have to go report to work because only 4 months. They get only how many days of maternity leave? Who knows about the maternity leave circular?
3 months, sir.
3 months, okay, in certain groups. Then
Half salary, sir.
sorry,
3 months with full salary, then another 3 months with half salary, then another 3 months with no payment.
no salary. Well, it is in different sectors different. Now, when it comes to the government sector, fully government, not this entities like universities does not come under the fully government. This thing is by act of parliament. No? So the fully government institutes 84 working days with full pay, 84 working days with no half pay, or 84 working and another 84 working days without pay if they want. So they can take 252 days of leave from the working days. Then certain institutes, the private sector will operate as 84 working days. So that means the public holidays, Saturday, Sundays will be excluded. Then there is another group which costs 84 days. That is what is coming under the Shop Act or something, and Shop Act or something is there. Where it's mainly for the commercial entities, not the normal, even the private sector. It is the shop and some act. I can't remember, right? So yeah, according to that, the institutes that are covered, that is mainly these sales institutes. Now, for example, somebody in like a Kagi or food, this supermarket outlets and all, those commercial enterprises which is operating on a small scale, not the listed companies, the small ones. Those ones are only providing 84 days. So when you say 84 days, it is only 3 months. When you say 84 working days, you are saying that it will be about 4 months. And then for the government sector, you have almost about 9 months plus. So like that, it will be there. So the mother is also available here. So that's why. So what is the answer? It's A, no. So introduce formula milk, not start complementary feeding, not in this case. Start iron supplementation, not in this case. Start multivitamin drops, not so. So how long can breast milk provide nutrients? Breastfeeding provide ideal food for the healthy growth and development of infants. It should provide all nutrients in adequate amounts. It should provide the adequate growth and development, both physical and mental. and occasionally some does not grow adequately on exclusive breast milk. So that's where we discussed earlier. We saw one who was at 5 months also growing nicely, but one at 4 months itself showing the deviation. So based now, this is one of the main things which will show that. So you can see that up to 5 months or so, more or less, majority will fulfill their nutrient requirements, especially the energy through mother's milk. But afterwards, gradually, this changes. So although we say 6 months, it does not happen exactly at 6 months, it changes. But some, of course, 5.5, 6. So for practical reasons, anything like 5 months and 3 weeks onwards, you can gradually begin to start complementary feed. So, but for practical purpose, for documentation, we say 6 months of exclusive breastfeeding. So this is the main reason the total energy requirement goes up naturally, but the breast milk will provide only less. And you will see why not it is going down. It can be straight like this, no? Because the child initially can improve the breast milk secretion, but it is not happening. It actually, the quality comes down. That is with the time providing, actually, that is not adequate food is provided. So this is where we go wrong. We think breast milk is the only thing, and we sometimes children keep on non-nutritive suckling. You will see that there are many children who just latch on to the mother's breast and keep on suckling. And as a byproduct, they will get the milk also. But the real reason why they are suckling the mother's milk breast is because for attachment and comfort. Just like some children choose to suckle their own fingers. So that is in a way is much better than suckling the mother's breast, because they will get milk, and then the milk is low quality, low calorie dense food item, which will just fill the room in the stomach, but it will not provide the adequate amount of calories. So then they will keep on going down. So the quality of the milk gradually goes down over the period of 2 years. So that's why afterwards, I of course don't encourage them to give milk. So therefore, the Sri Lankan guideline, 6 months of exclusive breastfeeding, weaning should never be started before 4 months, but start on weaning between 4 to 6 month period if mother is employed. So because other thing, sometimes the companies and all try to get the advantage. They say, amma nani, format denne kamat nani. Because exclusive breastfeeding till 6 months does not mean solids cannot be introduced. Solids can be introduced after 4 months, where there is something called extrusion reflex. That you try to put a solid particle into a newborn baby or a 1 month baby, usually they will spit it out. That is because it's a natural way of protecting, then getting choked. So they have to have a sort of a liquid diet in the initial phase. Then we go into the semi-solid. So after 4 months, almost all children can take it. Even 3 months old babies can take it. Or if you keep on carefully conditioning them, they will learn it. But usually, the reflexes are there to prevent them getting into any harm. So that is how it is being done. So then, if mother is employed, you don't have to start formula milk or saying that the child is still not 6 months. No. If the child is more than 4 months, then you can straight away start. Then the growth faltering, if occurs, as we saw earlier. So I hope the breastfeeding and the counseling and support in that is now quite clear in your head. Right? Any questions?
So why the diabetic delays the lactogenesis?
Sorry?
Why the diabetic delays the lactogenesis?
Well, I'm not 100% sure about what the pathophysiology behind that, because they have a lot of metabolic problems, probably because of that. Maybe the insulin resistance or something must be working. I'm actually not 100% sure about the real underlying pathophysiology. Sorry.
Why
Yeah.
are we giving breast milk until 2 years? Can't we stop before that if the parents
Well,
request?
you can give breast milk, but what is important is now breast milk is also another food item. Now, when you are giving breast milk or if you are giving one full item, you can give it on demand. Whenever, because there is no choice. No? You have to give whether she like it or not, or whether it's available or not. You have to give the breast milk. Now, once you start complementary feeding, you have to come out of this on-demand breastfeeding. Then it is structured. Now, afterwards, every food item has its place. And milk also becomes, if you see the pyramid, milk also a small portion. But it is, if it is available, you can give it. But what happens here is that they are kept on giving 24/7 breast milk. Because you can't give it because you are taking. Why we are starting complementary feeds is because the calorie density in milk is not enough. Calorie density in 100 ml is about 55 to 60. Whereas complementary food will have about 100, 120. So that will help to, in a small volume, to provide the maximum energy. Now, once you have started complementary feeds, the breast milk also have to be structured. It has to be given at regular intervals. Then you have to give maybe 4 o'clock or 5 o'clock early in the morning. Then you give the breakfast. After about half an hour or so, you can give. After breakfast, you can give. Then, of course, I advise them not to give. Just only give water to quench thirst. Because if somebody is thirsty, the appetite will go down. If not adequate water is intaken, then the gastric empty will be delayed. So then, of course, they can go on like that with water. Then around 10 o'clock, you can give a snack, maybe fruit. Then 10 after fruit, of course, you don't need to give breast milk. You can just give only water. Then after lunch, you can tell them to give breast milk and put them to bed. Again, maybe around 4 o'clock with a snack you can give. And then afterwards, it is only after post-dinner. So if the child sleeps at least 4 to 6 hours minimum at a stretch, that is much more important than waking up the fellow and giving milk. Then the other flip side is when you keep on giving milk throughout night, that it is water. So the child will every 2 hours or so will begin to wake up because he has passed a urine, and that keeps him waking up. So then what happens is his night is disturbed. So when they don't have a solid night's sleep, for you yourself, you all know, if you keep the alarm and every 2 to 3 hours you wake up, following day, even if you sleep 10 hours or 12 hours, till the following day, you will not be feeling very comfortable. That is one thing. Then another thing is that whenever they wake up, you burn more energy. So that means your energy for growth will be less in the child. So for those reasons, I totally discourage them giving throughout night milk feeds because it's counterproductive. It is not giving positive results. So the important thing is you structure the breastfeeds after complementary feeding is started. And then you reduce gradually the number of feeds that the child needs, because definitely after 1 year, he is very, very independent, going here and there. And then when the teeth begin to erupt, giving food, this thing, all the time will also cause problems. So it is important that you structure breast milk once you start the complementary feeds. Is that clear?
Yes, sir.
Although the WHO says 2 years and beyond, I always have been challenging that, because beyond is even 99 years, right? So it's a stupid statement, because people inside air-conditioned rooms in a country where it has never been not much of breastfeeding take place, they are telling. So those type of things, no animal, no mammalian I could see on earth other than humans go beyond breastfeeding after about 3-4 months of that type of period of life. So this is stupid, this thing, but of course we have to agree at the moment for that, especially for exam purposes. So you say till up to 2 years. But of course, important thing is breastfeeding should be structured, not on demand, because you can't use the word demand when there is other food items given, right? Is that clear?
Yes, sir, the question was actually, sir, should we continue until 2 years, or if the
Not
parents...
necessarily, it depends. But you should not stop prematurely and start because you want to start formula. Formula is not needed. Breast milk can be given, but the number of feeds have to be reduced till about 2 years. Usually 1.5 to 2 years afterwards you can stop. And then afterwards you want, because after 1 year they can take whole milk, cow's milk. Before that only they have to take the modified as a formula. So then they can take the fresh milk. Just
Okay, sir.
always these companies try to capitalize on a small loophole, because those are quite expensive and there is no value for money. So that's why you have to discourage the use of formula milk. Okay, is that clear?
Yes.
Yeah. So this one, they say the child is marasmic. What are you going to do? What do you need? What do you want? So these are things you will be seeing. Those who have been doing pediatrics would have seen these things. So what do you need? Oh,
So we can get the height and weight of the baby and also mid upper arm circumference.
height and weight එක තියෙනවා. දැන් මොකද කරන්නේ?
We also need mid upper arm circumference.
ඉන්න අපරාසකම් පෙච්චර බලන්නේ නැහැ නේ බැලුවා. හරි. 9.3යි. What are you going to do now?
We should calculate the height for weight and plot in the charts.
හරිද?
Yes.
මොකද්ද වෙන්නේ? So what's the answer?
Weight
So
is
is that
less
A?
than minus 3 ST is severely acute malnutrition, sir.
Right.
So we have to calculate the calorie requirement, start therapeutic food.
Now did you read this whole thing?
So the patient is getting admitted to the casualty night. So it might be a serious thing. And since it's suggestive of severe acute malnutrition, there is high tendency that the patient might go acidotic, and also hydration can also be a problem. But what I feel is that A is the better option, as is the arterial blood gas.
Assist the arterial blood gas and give IV sodium bicarbonate.
There may be acidosis.
So answer is B, hydration, and B, rehydrating with IV fluid.
So what is the difference between A and B?
The hydration we should correct within 48 hours, sir. Others we can do after.
Others. So the first thing to do is to correct actually the hydration, because marasmic children or malnourished children are dehydrated. And what is the special about their dehydration is? They mainly have hypokalemic and hypernatremic dehydration. So usually their sodium is relatively normal or upper normal. Their potassium is very low. So more than the normal ORS actually. low sodium, high potassium containing fluid should be used. Now, and when the child could be acidotic, but those acidosis could be due to dehydration. So dehydration acidosis can be corrected easily with rehydration. So giving bicarbonate is also not. But if there is severe acidosis, if there is Kussmaul breathing, then of course you have to think of starting bicarbonate. Then take blood for culture and commence IV antibody. Yes, you have to do it, but that is not the initial thing. Calculate calorie requirement and start on therapeutic. Yes, you have to do it, but that is not the very first thing. Assess rectal temperature and keep warm is also you have to do. So high correction of the hydration is important. A would be number one process. All these are steps that you may do. So B number one, followed by E, and then you can do C and A more or less together, and then feeding is the last thing at the moment, although we all think it is, because this is in the casualty or even in the other state if they come with acute illness. So the important thing is whenever you see a child, you have to have these two, plus you can't make a determination, because looking at this here, nice, fellow is having in the median -1 SD, right? But that does not mean that everything is normal. You have to look with the weight for length chart, otherwise you will be failing, right? So that is the important thing. Understood?
Yes, sir.
Right. So these are the definitions. So, and moderate acute. So these are the two charts which people may not know. Have you all seen these two charts before?
Yes, sir. Yes,
Koi dagal thi?
in the
Yes,
CSD.
dear.
Which page?
We used to follow generally the height and the weight pages.
Following the height and the weight. Nah. Koi kole pitipasset thiyen?
In the height chart.
Sorry?
Height.
Behind the height chart. Yeah. You all must be thinking I'm mad, no? Anyway, but you have to know, because we can see when people are asked to look, peruse this thing, people are looking up here and there to find out. So this will show that whether you are familiar with the CHDR or not. Sometimes these things matter when you're sitting on the fence, right? So sometimes the past abilities would be rewarded at the exam, because you should straight away know where these things are. So remember and know to flip the pages and see what is where. So that's why those days I have been telling students, always you are patient, you update the CHDR. That is some service you can do to them when you are doing the appointment. So severe acute malnutrition, timely presentation, compliance to treatment are the main things that would be dependent. So I showed you that a child who is just faltering weight at 4 months, if you don't pick them up actively, at 6 months, they would be really gone into a bad state. So it is important. So detection of cases early is very important. They may come for a fever episode, they may come for a vomiting episode, but in pediatric practice, of course, you always measure their weight. So you try to plot it. It will not take 15 seconds if you are familiar with the pages of the CHDR. So that can be done very easily. Sorry. So what are the reasons? Improper feeding practices, improper main meals, non-nutritive breastfeeding, non-responsive feeding. Lamanta kavano anime, they are obanava. So children even at 1.5 years don't know that they have to eat, because they have been watching the phone, and many of the people say we give the phone. Then my question is whether the child is eating out of Uber Eats, because you need the phone only for Uber Eats or whatever. Food does not pop up out of the camera, this thing. So what they are doing is they are just distracting the child. Child keeps the mouth open. Somebody makes a badguli and put it inside the mouth, and then the child just swallows reflexively. He had never consciously eaten. So always you have to tell them that to get them to the main table where the other people are feeding. And you would see in the earlier CHDR, Father and mother both are feeding the child in the middle of the living room. Then I told them, and now they have put at least the father is eating and the mother is feeding the baby. Actually, practically, even the mother can be feed herself. There they can save a lot of time also. Because otherwise, අම්මලා කරන්නේ කෑම හදනවා, කවනවා, ඊට පස්සේ අම්ම කන්නේ නැහැ. ඊට පස්සේ අම්මට කේන්ති යනවා. ඊට පස්සේ ගෙදර ඉන්න හත්මුල් පරම්පරාවම බෙරුම් ගන්නවා. So that has to be stopped because of the wrong value, not the wrong values actually. Wrong practices that they have adopted, they are getting into the difficult state and having very unpleasant way. Now, if you go to a Western country, you will see that the children are put whatever food item into the plate, and then they are given. When the adults finish, they also clean and go. They don't, nobody knee down in front of the child and keep on making this and that and showing this and that on the roof or the sky and feeding the fellow. So you have to tell them this responsive feeding is very, very important. When the child is eating, actually they should be talking, telling this is rice, this is a vegetable, whatever, this like that, and discuss. So that will help the child to interact, that will help the child to vocalize, and that will help the child to eat consciously, knowing that I am now eating. So those are very important. So these are the main things. You think for yourself, you all will know, your relatives and all, that this is what is happening. Then management basic investigations, you have to see whether there is any infection, then whether there is any nutritional deficiencies like anemia, then dietary assessment you have to do, and then identify any illness. So then you have to correct the underlying things with medical condition, nutritional deficiency, as well as structure of the diet, because that is the most problem. Because especially these days, children wake up at 9 o'clock, breakfast is given at 10:30, lunch is given at 4 o'clock, definitely, obviously, because they have been eating only for a short period of time. Usually we should eat from sun, not every time, but from sunrise to sunset we eat and be active, and then sunset to sunrise we should sleep. But what happens is many of the people are now sleeping at 12 o'clock in the night. ඊට පස්සේ y'all also come for the exam, දෙක වෙනකම් පාඩම් කළා, ආයෙ 4ට නැගිටලා ඇවිල්ලා එතන බයිලා කියවන exam වලට. I have told many of y'all, and remember that when you are coming for any exam, whether it's a continuous assessment, whether it's the main final MBBS, for God's sake, have at least 8 hours of sleep the previous day, right? Because in 12 hours you can't study medicine, one whole subject even, and then you have some knowledge in your brains, try to get that out rather than suppressing that itself. So that is even children will not eat. That's why when they keep on waking up in the middle of the night because of breastfeeds and passing urine, daytime they will have daytime somnolence. They will be feeling sleepy. So it's very important that anyone takes a good nap. Even 6 hours, it has to be a solid nap. So at your level, at least 6 to 8 hours you should sleep. So these are the things, whatever the age is. So Sam, without complications, with complications, I have done this. If there is no complication, that means good appetite, clinically well alert, then of course you can just manage them as outpatients. But if they have, so this is the feeding, you give instructions, basic health care, nutritional counseling. So you give some amount of therapeutic feeding. You have to give some prescribed diets and material like reduced therapeutic fruit, what you know as BP100. Then basic health care like sanitary vaccination, if not complete the vaccination, you have to give basic sanitary advice, how to be clean, how to prevent infection, all that. And then nutrition counseling is how to use the existing food items in the household effectively. නැත්තම් ගෙදර ඉන්න එළදෙනේ කිරි ටික විකුණලා කිරි පැකට් එකක් ගෙන ඒක නැත්තම් සතියක කිරි විකුණලා කිරි පැකට් එකක් ගෙනලා දවස් 4ක් මේව කරන. ඒව නැත්තම් ගෙදර ඉන්න කිකිලේගේ eggs ටික විකුණලා වෙන මොනවා හරි ගන්නවා. And now the trend is to buy for oats and apple and this and that. So you have to break that. You have the responsibility to the society to tell them what is the real value for money. Even you all should know, for every rupee you spend, to get the maximum out of that rather than spending 10 rupees instead of 1 rupee. Right? So try to utilize that way. Then loss of appetite, poor, all these things come into the complications. Then of course you have to admit them and you have to start inpatient treatment. So that is medical care for any of these conditions, and then therapeutic feeding you have to give them. Once they are done and the complications are over, then you can go on to that part and feed the then manage afterwards. Right? Is that clear? Right?
Yes, sir.
Not clear, please tell me. All have gone for tea.
It's clear, sir.
Yes, sir. Clear. Sir. It's clear.
පස් දෙනෙක් ගිහලා තේ බොන්න. හරි. කමන්නේ. 99ක් ඉන්නවා. 98ක්. Right, okay. So this is the chart. Of course, I have told you earlier also there is 10-point management කියලා කියන්නේ. So first week, initial, these complicated fellows, they have hypoglycemia, hypothermia, dehydration, electrolyte imbalances, infection, which you have to immediately attend. And then feeding comes little later even, right? You have to start on day 1, but micronutrients and initiation of feeding. But these are the more important things. And then so in these you correct the dehydration, electrolytes, all that. Then gradually, then when it comes to the second week onwards, you will start on the iron because it has its infection promoting action by inhibiting promoting the bacterial growth. So you have to start it a little later, but the other things. Then of course you will see, don't expect a growth or gain in weight on day 2, day 3, day 4. It will take even 2 months, 2 weeks plus, sometimes even in second week, mid 10 days, 12 days it will take. So stimulate the child, then you have to prepare for follow-up once he is in the rehabilitation phase. So what is the answer for this? What is the answer?
BP 100.
Yeah, it depends again the state. Now, for example, if the child has passed the SAM and gone to MAM state, moderate acute, then you don't have to give BP 100. Then you can give 3 right? So it is like this. We start here, severe acute malnutrition, feeding with all the therapeutic feeds, or in hospital you can give liquid diets, at home you can give BP 100. Then he comes here. So once he comes into the yellow part, he is not SAM but moderate acute MAM. Then you don't, BP 100 is not an indication. So at this point we stop the BP 100, but you have to give a little bit of high density food item. So BP 100 contains about 500 kilocalories per 100 grams, whereas other Tripos and that type of group will have about 400. So you introduce them into a nutrition rehabilitation program. Then you keep on feeding the fellow. So once he comes here, he is still, now afterwards he is not malnourished, but you don't stop them follow up, because if there is any loose, they will fall back. And even any subtle change, you have to pick up early and treat before they come late after losing a lot of weight. So then till -1 you go, because afterwards when the metabolism kicks up, their requirement for food is much more higher. So you will be able to satisfy the requirement through normal diet. So that way you can get it done. So this is how we manage them. So up to this point, you give therapeutic foods or reduce therapeutic foods, BP 100. Here, this part, yellow part, you give the supplementation. You continue that up to -1 because of the vulnerability. And then after -1, they have reached only, you will say, okay, stop, follow up. Any questions? If not so, what are you going to do here?
Sir, to the previous question, at the current situation, are we using anything instead of Triposha, sir?
No, I don't think so. We are using Triposha, whatever left over, but otherwise, no.
So, and in the previous case, uh, if we usually admit the patient, if there are any parameters that we have shown previously is there. Once
If
that
there
is,
is,
yeah, we have discussed now. So there, if the child is with complications, only we are treating the patient as an inpatient treatment. So once that is settled, can we discharge the patient and continue?
sorry, son,
Uh,
say it again, I missed it.
So in the SAM management, we usually, if the patient is without complication, we are not admitting them. No, sir. Only with the complications, we are admitting the child. And
Yeah, usually.
yeah, usually.
So one thing for the complication you have to take is a poor caregiver also. If the caregiver is really not up to the mark, careless, ill knowledge, then also that is also part of a complication you have to see.
Yeah, my question is that if the child, when the child is admitted at a SAM basis, on the basis of severe acute malnutrition with complication, once the acute complication is sorted out, can we discharge a child even if
Yes.
the child is in the SAM?
Yes. That's why, if the child is uncomplicated, running around, having a reasonable appetite, all those we don't keep them to the hospital. We can give straight away, even after the first diagnosis, you can give food and send them home. But if the child had been ill, you admit, you treat, but still the fellow is, you treat the medical, the complication, but still the fellow is SAM. Then you can still discharge and continue as a SAM, outpatient SAM management, and then you come to the MAM management. So that it's not a, SAM is not a contraindication to discharge the child.
Okay, sir. And if the child is with the complication, we usually start with very low very low caloric content foods, and then gradually we build up, no, sir,
Yes,
like
because
Respal, then
they have
F75 and B1,
they have
refeeding
this thing,
syndrome.
no, they have intestinal what do you call villus atrophy.
Sure.
So the villus atrophy can cause them to develop a diarrhea, osmotic diarrhea. So you have to give a little bit of time for the trophic action of the food to let the intestines at least 5-6 days to get the they get the villi and the endothelium epithelium develop. So till that time, so gradually you keep on increasing, because you can't give parenteral, no need. And the other thing is enteral food is important for trophic action and the development. Contact of the food intestine is much more important than giving in any other route. So you have to give it and try to build it.
So that kind of step-up regime is only for patient with complications, or even for the patient
No,
without
anybody I would sort of, it depends. Now, outpatients, of course, they have been eating something. So the villi will be functioning, but there is not much of calories that they are getting. But those who have diarrhea and all sorts of complications would be little bit on the low side. So that's why.
Okay, sir. Thank you.
Okay.
Yes, sir.
Right. So what is the answer for this? Hmm? What do you think?
His baby is born at 32 weeks. So though the baby is 10 months old, if we correct the age, it comes around 8 months old. In that case, the pull to stand doesn't pull to stand, and mature pincher grafts, other things are age appropriate, I feel.
So everything is okay. So you will say, Ame, everything is okay, go home. What is the mother's main complaint?
Small, very small.
Hello.
Her main complaint is that the baby is small.
Yeah. So what are you going to do for that?
Again, we have to objectively assess the child, and we can see whether it's really small, and if not, we can show that to mother and reassure.
Huh? When mother comes and say my child is small, what would you do? What is the objective thing you would do?
Measure the weight.
Huh? These are common sense things.
Measure the child's weight, length, and plot against the premature.
Somebody comes and say your hair is too long, what would you do? Not girls, boys. Huh? What would you do? Or if somebody comes and say you are fat, what would you do?
We objectively assess it.
මේ මත්ත ඇහෙන්නේ නැද්ද? ඉන්නව නේද? Hello there?
Yes, sir.
Oh, gone. Hello.
Yes, sir. We
Yes,
can
sir.
hear you.
Huh?
We can hear you, sir.
Yeah. So, what will you do? Somebody comes and say you are fat.
We need to measure the weight and height of the baby and plot in the
You come
premature
and
baby
say,
chart.
huh? So then, if they come and say small,
So we need to measure the weight of the baby and plot in the chart,
right,
sir.
you want the weight of the baby. Here I have given the weight of the baby. Now what?
We also need the parents one to see whether
Parents'
they
weight.
are parents are like, if the parents are also small, and like they are also not very high.
Huh?
We may need mid-parental height and all the things, because the
Yeah,
patient
but-
genetic potential of the child may be that much.
Okay, mid-parental height is about 160 centimeters.
We have to put it in the premature charts.
Oh, right. So premature chart is that. Why call it premature chart? Tibunne. Good.
Whereas corrected age is 8 months, sir, here.
So it has been corrected here and put it. So every time, so 2 months la mark kala තියෙන 4 month weight එක. All right. Okay. Then make it done. Right. So that is one thing, right? Then, okay. But premature charts, okay. Premature charts will say it's not available, because premature charts also again, it's a matter of just extending this. Right? Then, what else?
And the child's growth was in the same line from the birth, sir.
Yeah.
So
So,
it's the potential of that baby.
so you are happy. බය වෙන්න එපා කියලා ගෙදර යන්නද මොකද්ද ඔයා කරන්නේ? What else would you do?
Follow up, sir, to assess the progression.
Follow up තමයි ඉතින් කොහොමද මේ මේ වෙලාවේ මොනවා හරි කියන්න එපා. You have to tell this mother.
We have
Otherwise,
to
someone, she will go
we
to
have to
someone.
assess the height and put it in the weight for height and check, sir.
ඔන්න height එකක් තියෙනවා. What is your comment about this chart? Eh?
That's also like that. It's also following the same trend, but
Yeah,
we
more or
again
less
have to
is the same.
combine
So,
both them in the height for weight chart and see.
what is about the OFC you would like to comment? It's also closer to the height. Usually we interpret the length, sorry, OFC in relation to the length, right? So it is close about one standard deviation plus or minus wage range again. There can be differences, but usually it is matchable. Then, so afterwards, now you are going to say, what are you going to say? So mother says, oh, me podi yanawa තාම podi ne baba. So then how would you break that? How would you say this podi is normal?
We have
Height
to
for
ask
weight
the
chart.
mother.
Height for weight chart and see.
Height for weight එකක් නෑ බං. Weight for height එකක් තියෙන්නේ.
The
අයියෝ.
baby is keeping in the birth center, sir, so that's normal for the child.
It's normal when nෑනේ always.
And the development is appropriate, sir.
Development is appropriate. It's the physical growth, right? Now, are you happy with these two charts or you want anything else? You have to have this, no? We always want the human being to be in proportion. ඒකනේ ප්‍රශ්නේ. අපි මෙච්චර කාලයක් ගියේ most of the time we were trying to match this. We were trying to take it here. And then the height will not grow for parental reasons or intrauterine programming or whatever. So if there is comparison between the height and weight, that means this child had received reasonable amount of good calories and nutrients. That's why he's here. He's proportionate. Now, if this one is fed more, probably he will gain a little bit more probably. But he moved more like this. Now, if this child was here, then there's a problem. So the child is growing normally and his weight for age is, weight for length is matching. So that is the important component you have to see. So we have been used to just look at the weight chart and say, growth is good. So growth is not good. Now, you would remember previously I showed you another chart. No? Sorry, go ahead. When I make it, right? On this you can see the child. Now here you can see it is going slightly above and reaching even -1. And but the height length of the child is median. And then what happens is still is low. Now if this child kept on going like this, because somebody will say, right, මෙයා හොඳ මෙතන බැලුවාම තියෙනවනේ normal range කියලා මේක ගියා නම් still he would be Sam or Mam. So you have to always use this or the BMI chart. Is that clear? තේරුණාද?
Yes, sir.
Right? So always remember, once in 6 months you should measure the height of the person or the length. And then at that time you have to update this. Then you will know whether the person is, because less than 6 months measuring the height is no point. So you measure at that point and then you will see what is happening. Okay, is that clear? So this is an eternally common complaint. So you have to tell your baby is small. He was born at 32 weeks, maybe for some reason. And it could be potential was not there. So maybe even a spontaneous destruction of that embryo or the fetus would have been the nature's requirement. But today the science is developed. So we give life to them, not only them, even 24 weekers, 22 weekers, we give life. But of course at a price. So you have to see this. So then you say, okay, right, your child seems to be less in weight, less in length, but of course the two are matching and the child is doing well. If you feed them more, try to get their weight into a bigger place, they will put on weight, but they will not become grown very well. Is that clear? Lamaini?
Yes,
Yes.
This is the disadvantage of this Zoom technology. Hari, what is the first step in the management of this child? Huh? Quickly. Huh?
A.
A. Yes, you just continue and you just make sure that the correct feeding techniques are done. So you have to look into that, the frequency, unnecessary food දෙන්න නැතුව. හරි food එක දීලා, exercise කරලා, ඒ ටික ඔක්කොම ඒ techniques ටික you have to follow. There is no requirement. We have not told anything about iron requirement. Thyroid function development is okay. Urine culture, there is no faltering for you. And there is no requirement to start formula milk. Right? Okay? Hari. So this one. Think simple. There is no magic here. There is no catch here. So what it is here?
This is acanthosis nigricans, suggesting that the child is having some sort of insulin resistance and high tendency to have a metabolic syndrome. So our approach would be to see whether this child is obese and manage and try to control the obesity and related complications.
Yes. So establish the nutritional status obesity, assess the metabolic derangement like glycemic problems or cholesteremia, hypercholesteremia, things like that, and then do the relevant treatment. So treatment in the sense, you have to diet, physical activity. If there are any metabolic derangement like hypercholesteremia, impaired glucose tolerance or whatever, you have to treat that. Right? So that's why think simple. Any questions on this part?
So, excuse me, sir. The previous one, until which age do we use the premature chart, sir?
Premature chart till 6 months of age. At 6 months, because it's only actually we used to correct them till 2 years. But the current premature charts which we have got from the intergrowth study is going only up to 6 months of age. At 6 months, you have to transfer it to the normal chart. What we have.
Okay, thank you, sir.
Excuse me, sir.
Yeah.
When we are transferring to the normal charts, how do we mark it as it
මාස 6 ගත්තේ මාස 6 අතරින් මාස 6 ඉවර කරන එක මෙතන මාස 6ට දාන්න.
Okay, sir. Not as corrected.
No. So that's why there is a little bit of a cockeye thing there. So that's why using the old chart. I mean, people mainly for epidemiological purposes, they are using different charts and cutoff. What is important is to see at the pattern of growth. So the pattern of growth, whether it is Alaskan children or Eskimos or Aborigines or Sri Lankans or whatever, it is same. But their composition and the trait and things are going at different. But I don't think you should clutter those things in your mind at this point of time. So what you have to do is you just know what is happening in the country. So those are much more different level of discussions and things like that. But of course, having a critical view of these things is also good. But at the moment, it is working like that. Okay? Hello?
Okay, sir.
Right. මේකට මොකද කියන්නේ?
A true, sir. B false.
Yeah, ඊළඟ.
True, sir.
False.
True, sir.
True.
Not really. It is giving satiety. It is not control. I mean, you can take it that way also. Well, I think for your purposes, it will take it as true. Leptin is an important hormone, CNS control of endohomeostasis. Yeah, I think yes, take it as true. Sorry. Okay. Right. Ilanga overnutrition. So obesity is actually excess body fat. It is nothing to do with BMI, but BMI is used to measure that. So one thing is BMI. Then of course we also use the weight to height, waist circumference to height ratio. That is, your height should be, or the waist circumference should be less than 0.50% of anybody's height, because that will give a much more focus onto the abdominal obesity, because sometimes the BMI could be high even in a person who has high amounts of muscle, who is a bodybuilder and all, they could have a high BMI. But what we are interested in obesity is abdominal obesity. So as a result of that, waist circumference to height ratio, and it's very easy, spot on, you can measure it, is also getting more prominence, and commonly it is being now used. So these are the cutoff values. For under 5 years we use weight for height or weight for height. Above 5 years we use BMI. So under nutrition, of course, the same standard deviation cutoffs in the two charts. But when it comes to overnutrition, usually obesity is +3 standard deviation, whereas overweight is +2 to +3, and BMI is +1 to +2, and overweight is above +2, right? So that is the standard way of looking at it. Okay, right? So these charts you all know. No? So any suspected metabolic syndrome, when they are having acanthosis, you have to suspect they have some form of insulin resistant related problems. So just don't ignore. Definitely, sometimes they may have marginal high BMI still, but that could be a high fat content in their body, which is giving rise to insulin resistance. So goals of management: reduce weight, treat any morbidity, psychological adjustment, because this is a habit that you have to treat. They are not feeling ill. You are trying to deprive their normal life is what they demand. Right? So like that. So the basic investigations: after 12-hour overnight fast, you can do a fasting blood sugar repeat profile ALT/AST. Then you can do a oral glucose tolerance test, but get this correct amount. 1.75 to a maximum of 75 is anhydrous glucose. So what we have is, with every glucose molecules with one H2O molecule. So you have to add that 18 grams to the 180 grams of the molecular weight of the glucose. And then you do ultrasound scan to see what is happening inside the liver, whether there is any fat deposition. Okay. So then management of obesity: behavior modification, change in dietary pattern, activity pattern, increase physical activity, reduce sedentary activity, and providing psychological support. So diet, you give a prescribed diet more or less. Activity you have to increase. So increase physical activity, reduce the sedentary behavior. That's two different things, because now what I am doing, I am just talking, that is almost a sedentary activity. But if you walk here and there, even if you take the without, you close this and walk here and there, or you all close the lecture and you walk here and there, that is at least you are engaging some amount of physical activity. So then providing psychological support. Then pharmacology, we use metformin in resistant cases who are not working out dietary manipulation, as well as those who have insulin resistant features. Surgical treatment is not very much for young children, but adolescents it is now gaining popularity, and especially with very high degrees of morbid obesity. Sorry. What is this? Any questions on the first part?
So why do we have to fast for 12 hours to do AST and ALT?
We don't do actually fasting for 12 hours to do AST/ALT. When we are taking blood for that, we don't have to wait. We take blood for all these three together. There is no impact on the fasting to ALTST. In one prick, that is what you have to learn also. You have to plan out your investigations, and in one prick you try to take the maximum. So what we need is the fasting only for these two. But by taking a fasting blood, this will not get affected. You don't have to have a fed. But the OGTT will get affected. That's why we do it in a different way. Understood?
Yes, sir.
Even a fasting blood sugar, fasting full blood count could be done. There is no issue.
Sir, in obesity in child, should we reduce the weight or should we maintain the weight till the child gain height and correct the BMI?
Well, if they are just above my +2 standard deviations in the BMI, less than mine +3, then of course, and if they are pre-pubertal, yes, you may maintain some amount, right? If you can maintain. But of course, those who are having high amount of obesity, that means more than +3, it's always better to bring down at least some amount and then make sure that you maintain. But in the post-pubertal ones, of course, there is no chance of losing. So you have to, so no chance of normalizing it because the height gain is more or less static. It's almost completed in the peripubertal or the post-pubertal especially. So you have to reduce the weight. So pubertal assessment is also important in a way. Okay?
Okay, sir. Thank you.
Anything else? Any questions? Otherwise, we'll go to this one quickly. That's it.
False.
Oops, sorry. Night blindness rate is a good public health indicator of vitamin A deficiency. Yes, because you can't assess it properly. Then, Ilanga?
False.
No, it is true. Sorry, false. Sorry. Because, why?
The child will get vitamin
Vitamin A megadose in first trimester is teratogenic. You don't give. You give it immediately after birth and less than 2 weeks or 4 weeks before there is a danger of they getting pregnant. 2 weeks, I think. Those who are doing gin and obs, find out. With the BCG, usually they are giving it. I don't know whether it's happening these days, but that will improve the breast milk vitamin A content. Hari? So it is tetragen. You never prescribe vitamin A mega doses during pregnancy, basically. See?
False.
False. Why? Huh?
Because there is usually a high tendency to have vitamin A deficiency.
And
Usually there is a high tendency to develop vitamin A deficiencies in newborns. So if we wait for biochemistry confirmation via biochemistry, that might be too late to intervene.
so if they develop vitamin A deficiency, so now they are saying vitamin A deficiency theanol. So we don't have to wait for biochemical disease. That's what you said was true. That is, this sentence is false. So why we don't have to do biochemical assessment?
For the clinical manifestations, the levels has to be very low.
How do we know whether our diagnosis was correct?
So even in suspicion, we can give, sir, it won't do any harm, sir.
harm නැතු ඕන දෙයක් කරන්න කියලා පස්සේ කාලේ තමයි harm එක එන්නේ. ඊළඟට අර කොරෝනා වැක්සින් එක දීලා දැන් harm එකක් නැහැ. නෝ පස්සේ ඊළඟ ඒව ණය ගෙවන අපිට වැක්සින් ගාපු එකට. ඒ වගේ තමයි. Right. That's okay. No, that a real thing is that in no time it can progress into a disastrous complication. In other words, in the what they say is it is like this. Even in the morning you see vitamin A deficiency, you suspect. Following day you come, he may have lost his eye, even blindness, right? So the progression could be very rapid. And then, as you said, giving 1 or 2 mega doses is not going to kill the person because the danger level is very, very high. And so it is considered as a medical emergency, right? Vitamin A suspected vitamin A deficiency. That's why vitamin A studies cannot be done as placebo control studies. If somebody wants to see vitamin A deficiency එකක් බලාගෙන ඉන්නවද කියලා නෑ. There is nothing to say that you have to treat them immediately. So if you suspect vitamin A deficiency, immediately treat. Is that clear?
Yes, sir.
Right. ඊළඟ D.
False.
False.
Yes. They are not all reversible. If the cornea is damaged more than 1/3, then of course you can stabilize it at that point, but it will not reverse. But other things like mitospot, corneal cirrhosis, those are reversible. Then last one.
False.
False. Well, it's false. The truth can hide it, but it's actually false because it's not no more a public health problem in this country. Because vitamin A levels, which we have studied in almost every study in the recent past, had shown very good levels. Okay, so night blindness is like this. This is how a normal person sees. This is how a vitamin A deficient person sees, only the bright thing. So what will happen to this person who sees this and go towards this light?
Get himself injured by hitting.
Huh?
He'll get himself hit and injured, sir.
Yeah, he will hit this furniture. So this is actually when the bright lights are not lit. Basically this now, if this is, there will be reasonable amount of light around with this good candle. But what they say is dawn and dusk. There is a time where light දාන්න ඕනෙත් නෑ, light දාන්න ඕනේ, ඒ වගේ නිකන් not the night, not the day. That type of a thing where you may just walk with very, very minimum amount of light. They are the ones who will knock on the furniture at that time. So you have to ask, dawn and dusk, when you walk in the house, do you hit on the furniture? That is the usual question you have to ask for night blindness, right? So that you can see this is the best way to depict it. So these are corneal cirrhosis, and you can see that there is a numbering way of saying it. If it goes more, it becomes spots, and then it could be treated. There are number 2 also, but X3 is that there is corneal scarring. So if there is less than 1/3, these are more or less reversible. But if it is going beyond that, of course, it will be scarred. Right? Any questions on vitamin A? If you see any dry, fairly dry eyes in a non-dehydrated person, no harm giving 1 or 2 doses. So how you treat it is, you give 100,000 or 200,000 below, between 6 to 12 months it is 100,000, about 12 months to 200,000, day 1, day 2, and day 28. For children below 6 months, you give 50,000 units. Prophylactically, we give either 100,000 or 200,000 every 6 monthly or so. Either. Okay, this one. Oh, Nidita. Click. What's happening? What's the answer?
B, sir.
What are the problems here?
The answer would be F, sir.
F. Anyone else? Anything else? Sorry. F නෙමෙයි අතන sorry. C එකක් වැරදිලා වැටිලා තියෙන්නේ. Right, okay. It's 5 answers. C is part of B. Okay. Yes, so there is iron deficiency. Now this all blah 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 is there separately. You have to look for 9-month-old baby presently routine vaccine. Mother complaint has poor appetite. Weight for age has dropped below median because of poor appetite. He was exclusively 6 months. So there is 3 main meals complementary food will start at 8 months. Parakvela. Each meal is taking about 3/4 of a cup and mainly rice and potatoes. So animal food not introduced. So in other words, it's an iron deficient diet in a child who was actually started complementary feeding later and also gave a iron poor diet during the first 6 months of life. And then looking at this, so the poor appetite and all is also part and parcel of iron deficiency, anemia, iron deficiency per se. So platelets are high. That is, of course, a reactive platelet increase you see in most of the anemic children, 8.6. So then MCV is microcytic, hypochromic, and the RDW is 19. Anything more than 15, you have to suspect as iron deficiency. So you start them on, you don't do any other test, no need. You can straight away start them on iron treatment because this is the commonest. So you give 6 milligram per kilogram in 2 divided doses. Give it for 1 month, and at the end of 1 month, you do a hemoglobin and see. So if the rise in the hemoglobin is 1 gram or more, then you are certain it is iron deficiency anemia. In my experience, of course, anything more than 0.8 grams, you take it as a iron deficiency anemia is confirmed. Then you treat it till the hemoglobin comes to normal, and then for another 3 months, half of the dose till hemoglobin, iron stores are replenished. So that is how you would treat. Is that clear?
Yes, sir.
Right. Maker.
So the rise should be how much after the iron treatment?
Sorry?
The rise of hemoglobin, how much should be after the iron treatment?
1 gram usually textbook says in Sri Lankan context I would take 0.8 grams. Right? So any answer should be 1 gram. But for practical reasons, it is anything more than 0.8, you can take it as positive. Okay?
So are there any cutoffs like to say at this point we have to start and at this point we have to intervene in some other ways?
No, no,
Are there any
there's
concerns?
nothing like that. You have to treat the underlying thing. No. So if it is iron deficiency, now if this child came with a 3.5 or 4 hemoglobin and he's panting, he's having tachycardia and lethargic, respiratory rate is high, then of course you have to straight away give a blood transfer. Otherwise, in heart failure features. So it depends. Understood?
Yes.
So one thing is you have to, in any condition, you have to you counteract the complications separately. You counteract the underlying problem separately when you're treating. So the complication in that case is heart failure. Heart failure in that case you will treat not with digoxin or captopril or anything, but with blood transfusion. And then afterwards you give the iron treatment to replenish the iron. Harida. Okay?
Yes, sir.
Right. Maker.
A true, sir.
A true.
True, sir.
True.
How long?
To 2 years, sir.
Yeah. Okay.
True, sir.
C false.
Huh? Sorry? Say what you have to try to say somebody? Somebody try to say something. I know that there is a doubt problem.
No, sir. I thought C is false.
Yeah, that is because you thought it is essential. It is not essential, but it's a useful investigation.
Okay, sir. Yeah. Right.
Probably it would have struck you as an important or essential investigation. No, because discussing from the previous, I showed how to diagnose iron deficiency anemia to a great extent, right? Especially in a resource poor setting. So this is the useful investigation. True. If it was essential investigation, then it's false. Right. So that's why if you don't ask a question, I can't may explain to you. And you are at disadvantage. You more than that, you don't get a clear knowledge. You will think that at one point I said one thing, the other point I said the other thing. Those are contradictory, yes. But one catchy word here is useful.
True, sir.
True, sir.
Yes, that is being practiced now.
Yes.
Yeah.
Yes.
So then
That false.
False.
හැමදාම තියෙන එකනේ. හරි. ඊළඟට, so this is what happens in the newborn. A term newborn baby will have good stores provided the mother is also not anemic or not iron deficient. And then after 4 months, දඩාංගාල මේක නවතින්නේ නැහැ මෙහෙම. But it comes down and this is the requirement. So you can see it goes almost empty while breast milk gives a very, very small amount. So breast milk provides iron, but it is not even 5% of the requirement. It's very, very small amount. It can't. Yeah. So the WHO recommended. So this is the only flip side of this 6 months exclusive breastfeeding. You can see, no? මෙතන මුකුත්ම නැහැනේ. The exclusive breastfeeding කියනකොට මාස 6ක් යනකොට sometimes this will happen, especially in iron deficiency. So that's why they said 3 milligram for iron starting from 3 months could be given. What we do here is when we are starting complementary feeding, we are giving MMN. So if MMN is not available, it's no harm giving iron 3 milligram per kilogram daily for about 2 months. That will help to improve. So that of course I practice every time when we start complementary feeding, because if they are iron deficient, you know the metabolisms in the body will be low, and then the appetite will be low, and then he will not really take food, because especially there should be good appetite when you are introducing a new food item. Otherwise they have to like it, they have to have starving, because they may dislike it, but if they are hungry they will eat, and once they keep on eating only, they will really develop a liking. So because of that you have to give them that way iron. So complementary feeding when you're starting, or even before that if necessary, you start it. So clinical approach, screen clinically for anemia, establish anemia hemoglobin measures, which we discussed this in the case scenario we saw. So RDW, anything more than 15% in this country, I take it as iron, I give a trial and see. So these are the cutoffs at different ages. So usually we take for children under 5 years 11, 5 to 11 years 11.5, and then 12 to 14 years 12. So adolescents. So adolescents and non-pregnant women are same, whereas pregnant women and infants are more or less same. Adult men 100 is 30. Okay, right. So treat with hematinics, that is 6 milligram, 2 divided doses, folic acid and vitamin C you give. Review, and of course, I add a little bit of zinc also, because zinc is also important for enzyme activity, although it is not really recognized as a hematinic. So as I told you earlier, we do 1 month treatment and then increase, we'll see. If no response, investigate for other causes of anemia. Harid, any questions?
Sir, in this context, before starting the treatment, shouldn't we do the iron studies on this baby, sir?
We do the
Before starting the therapeutic iron supplementation, sir, shouldn't we do the iron studies?
We should do iron studies in ideal setting, but if we don't have resources, then it is better to do the therapeutic trial. It is accepted. Even the American Academy of Pediatrics gives that recommendation. Why do we want to waste money when iron deficiency is the worst leading nutritional deficiency? And then on top of that, we have this thing. On top of that, that is the easiest way. So that's why I said you treat for 4 weeks, see what happens. If that is not, I mean, you're not going to treat somebody who is having a 3 or 4 milligram iron. I'm talking about 7, 8 moderate, mild iron, anemia. So you treat and see, and then if not, you do the next investigations. Anything else? Any other questions? Yeah.
So do we give iron until they reaches the normal hemoglobin amount, sir?
Yes.
Is that the target?
Treat monkey whistle treatment 6 milligram, you give it till the normal. So if it is a 4-year-old child, till he becomes 11. But that is only to treat the anemia. Then you have to improve the stores. To give the stores, you give half of this dose, half of this dose, 3 milligram per kilogram daily for another 3 months to replenish the stores. So 6 per kg till not for 1 month. If 1 month to find out whether they are getting better or not. And then you treat it. So if it was 8.9, it becomes 9.9. Next time becomes 10.9. And then till 11 you give it. Then afterwards you continue for another 3 months a prophylactic or a supplementary dose. Okay?
Okay, sir. Thank you.
Right. Okay. Shall we call it a day or anything else you want to know?
Sir, I have a question regarding the express breast milk definition.
Yeah.
In that, sir, if the baby was given IV fluids, does that
complementary feeding? I mean, exclusive breastfeeding.
Yeah, exclusive breastfeeding.
Well, if it is provided, then exclusive breastfeeding is no more than ඇත්තටම බැලුවොත්. But that is actually, but again, that will be for medicinal purposes. No, so it will not really affect. It can't be affected by the definition because it is given for a medicinal purpose.
All right. Okay.
It's treated as medicine. No, එදා මේ කන්න බැරි හින්දා නිකන් මේ බොනවා වෙනුවට IV ගන්නෙ නෑනේ.
Yeah. Okay, sir. Thank you.
So it comes as a medicine. Anything else? හරිද?